Hello and welcome. I'm Dr. Rita Nanda, and on behalf of Creative Educational Concepts, thank you for joining us for today's educational activity entitled Maintaining Patient Quality of Life Through Optimal Management of ADC-Associated Adverse Events. Today's program is supported by an independent educational grant from Gilead Sciences Incorporated. This activity may include discussions of products that are not currently FDA approved for all indications that we discuss. Again, I'm Rita Nanda. I'm an associate professor of medicine and director of breast oncology at the University of Chicago Medicine in Chicago, Illinois. Joining me today is Jen McKenna. She is a nurse practitioner at the Breast Oncology Center at the Dana-Farber Cancer Institute in Boston, Massachusetts. We have one learning objective for today's short program, and it is to apply interprofessional strategies to prevent and mitigate adverse events while collaboratively promoting quality of life for patients. We'll start by listening to a video from Ms. Michelle Benjamin. Ms. Benjamin is a young woman living with metastatic triple-negative breast cancer.
What are the side effects of ADC? It's very important to explain to patients what the side effects could be, the possibilities and how they can make them feel. Although, every patient is different, giving some alternatives or ways to manage it is very important because, patients have this fear, what is wrong, what is happening. So at least if they have some tools in their toolbox already to kind of be aware of it and ahead of it, it makes the patient feel more comfortable with dealing with it.
So Ms. Benjamin raises some really interesting concerns about side effect management for patients who are on antibody drug conjugates. Jennifer, can you talk to us a little bit about the benefits of early side effect management?
Sure. So the goal of cancer care in the metastatic setting is to keep patients on their anti-cancer treatments that are managing their cancer for as long as possible. And one of the things that's very important to do with that is to manage the side effects. And it's very important to promptly identify significant adverse events associated with all treatments, including ADCs, to really improve patients' quality of life. We really need to include specialists, for example, ophthalmologists for organ-specific AEs. And we need to look at overlapping toxicities when combining ADCs with other therapies, and interdisciplinary collaboration to address all of these challenges is really critical. And of course, we really need to encourage our patients to discuss their symptoms and their side effects so that we can manage them together.
Yeah, that's really important and some great points. We currently have 3 antibody drug conjugates which are approved for HER2 negative metastatic breast cancer: sacituzumab govitecan, datopotamab deruxtecan, and trastuzumab deruxtecan. And all 3 of these ADCs have been comprehensively reviewed in the first activity in this series, where we talk about the structure and mechanisms of actions of these different ADCs. And I would encourage you to consider watching that first program. But in short, all 3 ADCs have potent bystander effects. Sacituzumab govitecan and datopotamab deruxtecan target TROP2 on the surface of epithelial malignancies. And trastuzumab deruxtecan, as you all know, targets the HER2 antigen and is approved for both HER2 positive metastatic breast cancer, as well as HER2 low and HER2 ultra low disease. So again, I encourage you to watch that first activity to learn a little bit more about these ADCs. Jennifer, can you talk to us a little bit more in depth about sacituzumab govitecan?
Sure. So sacituzumab govitecan is approved for the treatment of metastatic triple-negative breast cancer for patients who have received 2 or more lines, and also for estrogen-positive HER2-negative metastatic breast cancer. In the clinical trials, they enrolled patients who were heavily pretreated, who had more advanced cancer. So these patients had both cancer-related symptoms and side effects and toxicities from prior treatments. The payload for sacituzumab is SN38, which is the active metabolite of irinotecan, and it is metabolized by the UGT1A1. The ASCENT trial, which led to the approval, this is a slide showing the AEs, and you can see that boxed are neutropenia, diarrhea, and nausea, which were the most common and troubling side effects with sacituzumab.
You know, I have to say, in my own personal practice, neutropenia is definitely something we see and generally can be manageable with the institution of growth factor or dose modification or both as needed. So, really quite manageable in the way of side effects.
Agreed. And this is just a slide looking at the TROPICS study, which led to the approval for estrogen positive, HER2 negative breast cancer. And again, you can see that the boxed AEs are the same, the neutropenia, diarrhea, and nausea.
Yeah. And I think, again, we're seeing, you know, primarily grade 1 and 2 toxicities. The only really grade 3 toxicity we see with high incidence is the neutropenia. And again, really manageable. So reassuring to see that regardless of receptor subtype, that patients are equally benefiting and tolerating this therapy. So tell us a little bit about the diarrhea and how we might grade that for patients. You know, being SN38 is the active metabolite of irinotecan. We know that irinotecan can be associated with a fair bit of diarrhea. I will say, with my experience with SG, I'm definitely not seeing that same degree of diarrhea that we see with irinotecan. It's definitely mitigated. But talk to us a little bit about how we grade diarrhea and how we manage diarrhea based on the grading.
Sure. So, you know, you can see here the different grading. So, grade 1 is an increase of at least 3 stools per day over baseline, and grade 2 is 4 to 6 stools per day. And this is when patients really start to, with grade 2 diarrhea, they feel like they can't really leave the house comfortably. We don't dose modify for grade 1 or grade 2, and we maximize supportive care. But then when we get to grade 3, and certainly with grade 4, which can be life-threatening, often hospitalization is indicated. And then we need to hold dose, and we need to dose reduce once we restart. But it's very important to educate patients about how to manage the diarrhea before they even start. That is really critical.
Yeah, no, I think that's a really important point, and to notify their care team as soon as possible so we can hopefully
Exactly.
avoid getting to the point where they get admitted. Yeah, so I think, you know, really important. Any other tips about managing diarrhea? You know, we've learned how to grade it, and obviously we have supportive care measures, but are there other things that are important to think about in these patients with diarrhea?
Sure. So we always want to make sure that the diarrhea is not for some other reason. So for infectious causes like C. diff. And so we need to evaluate for that, particularly in patients who maybe have had recent antibiotics. And if there's no infectious etiology, then we instruct our patients to use loperamide, 2 tabs after the first episode of diarrhea, and then 1 tab after each subsequent, up to 8 tabs in a day or 16 milligrams. But certainly we want our patients calling us long before they need 8 tabs of loperamide in a day. And we will often, if patients are struggling, we bring them into the clinic for IV hydration, check electrolytes, replete electrolytes. And we're always instructing patients over the phone, trying to manage them at home, to eat a bland diet. We often recommend a brat diet, bananas, rice, applesauce, toast, and to hydrate well, particularly with fluids that have electrolytes in them. That's quite important. It's also very important to make sure that patients stop loperamide once their diarrhea has resolved, because we often have patients that then rebound into constipation, which is also very uncomfortable. And then it's this real back and forth, which can be really impactful to quality of life.
Yeah, Jennifer, those are really important points. You know, fortunately, grade 3 and 4 diarrhea is pretty uncommon, but, you know, certainly recognizing these patients who are prone to it or susceptible to it and being proactive, I think is really helpful. And thank you for outlining that. Neutropenia is obviously something we do see a fair bit with patients who are exposed to SG. Can you walk us through a little bit about neutropenia grading and management?
Sure. So you can see, so grade 1 and grade 2 are really quite mild neutropenia, but once the ANC falls below 1,000, that's grade 3, and below 500 is grade 4. And ANC below 500 plus fever is, of course, febrile neutropenia. And patients that are at higher risk for this, older patients that have, reduced bone marrow reserve, they can have more profound or prolonged neutropenia. Certainly patients who are heavily pretreated might have reduced bone marrow reserve and they are at higher risk. Patients who have poor nutritional status, that can really exacerbate the neutropenia. And then patients with a lot of comorbidities, which is many of our patients. And there are also certain medications, some antibiotics, some anti-seizure medicines that can also decrease the white count and can make neutropenia more problematic.
Yeah, I know in my own practice for patients who've struggled with neutropenia on prior lines of therapy, many times I will consider starting them on growth factor as primary prophylaxis, or perhaps even starting at a slightly lower dose and seeing how it goes. I think are all strategies that we can use for these patients. But again, quite manageable, the neutropenia, either with the institution of growth factor or dose modification, or even both in certain cases. I don't know if there's anything else you wanted to add about, trastuzumab deruxtecan and what the guidelines are for managing the neutropenia here.
Sure. So, we are holding the dose for grade 3 neutropenia with TDXD and sacituzumab until it has resolved. And if there's grade 4 neutropenia or febrile neutropenia, of course, we are holding until it has resolved to grade 1 or lower, and then we resume, but we dose reduce always. And again, we consider using growth factor to help with this. Often with sacituzumab, we will use on-body Neulasta on day 8 to help maintain their white count throughout, so that we can hopefully keep them at the same dose.
Yeah, no, I think those are really important strategies. I have to say, in my own personal practice, I've definitely seen more neutropenia with SG than with TDXD. I don't generally see as much profound neutropenia with TDXD, but again, every patient's different, every situation is different. So I think that, that's really important to sort of recognize in these patients. Can you talk to us a little bit about UGT1A1 polymorphisms and how you incorporate that into your practice?
Sure. So this is an enzyme that is involved with metabolism of the sacituzumab. And there are differences amongst racial and ethnic groups. You see much higher incidence of poor metabolizers in the African American and Afro-Caribbean population, and also higher in the Latino population. And so we want to pay particular attention to this. There is a commercially available test for UGT1A1 polymorphisms that can be sent. I'm not sure, Rita, if you routinely send those for your patients before they start sacituzumab.
I do not. I don't know if that's part of your practice, but I think, when we look at the clinical trial data and the presence of these polymorphisms, I don't think that I've necessarily seen such severe neutropenia that I felt the need to routinely incorporate this into my practice. And a lot of times time is of the essence when we're trying to get patients started on therapy. Do you do it, Jennifer, at Dana-Farber?
We do not routinely do it. I have heard of, here and there where providers have ordered it. And I think that is when they're with patients that are particularly frail or they're worried about, but not routinely.
Yeah, same. I think it's unclear that we really even need to. I think with irinotecan, it potentially makes more sense, but with the sacituzumab govitecan, I think a little bit less of a real role for the testing. Again, it's being done in the context of clinical trials, but I don't think that it's necessarily impacting patient clinical care. Can you talk to us a little bit about datopotamab deruxtecan, which was just approved for hormone receptor positive metastatic disease last year?
Sure. So Dato-DXd has recently been approved for estrogen positive, HER2 negative metastatic breast cancer. And again, the clinical trials enrolled heavily pretreated patients with more advanced cancer. And so again, quite important to manage the toxicities and to think about the toxicities that patients have had from prior therapies and their cancer-related symptoms.
And what side effects were seen in some of the early studies that have investigated Dato-DXd?
So side effects that are particular to Dato-DXd and quite different from the other ADCs we've talked about are ocular toxicity with dry eye in particular, but something that, if not addressed, could progress to keratitis, and then stomatitis. And so we use preventive measures to help with these side effects in particular.
Yeah, no, I have to say I used Dato-DXd in the context of some neoadjuvant studies, and the dry eyes and stomatitis really can negatively impact quality of life. You know, the dry eyes can lead to blurry vision and can make it really challenging for patients to read or drive.
Right.
And I think, you know, or can be quite irritating. So I think prophylactic eye drops are really critical here, and the stomatitis as well. You know, it's interesting, some patients do just fine, and then other patients have really terrible stomatitis. And so it sounds like you are also incorporating prophylactic mouthwash into the regimen for these patients. And that has really been game changing for these patients, and is really important to think about, because if we don't do these prophylactic eye drops and prophylactic mouthwash, we're really going to have patients who have a very negative impact on their quality of life. So thank you for pointing those out to us, Jennifer. Can you talk to us a little bit about mucositis in datopotamab deruxtecan use, and how we might grade that mucositis?
Sure. So, grade 1 mucositis is really when you can see some erythema on exam, but patients really aren't experiencing any difficulty or pain. And grade 2, when you can see some ulcers, and patients are maybe altering their diet, not having kind of, hard, crunchy foods that can irritate their mouth. And then grade 3 is ulcerations, where patients really are having trouble with their oral intake. And then grade 4, with tissue necrosis and spontaneous bleeding, is something that we really very rarely see. And I think that is because we've been very proactive with preventive mouthwash.
Yeah, no, I think. And what about the incidence of mucositis with the various ADCs? I think we see it a fair bit with Dato-DXd. What about with TDXD or SG? Any sort of experiences there?
Sure. So I've definitely seen mucositis basically with any agent we use, any chemotherapy agent. But with sacituzumab and TDXD, we see it, but much less common than with Dato-DXD, and less severe, and much easier to manage, I would say.
Yeah. And I'm not using preventative mouthwashes for
No.
any of those patients. But again, we talked about how prophylaxis is really key, particularly with Dato-DXd. I've definitely had patients use ice chips, but it's unclear if that's really very beneficial. But the mouthwash absolutely has been beneficial. What do you recommend to patients in terms of dietary alterations that they can use in preventing mucositis?
Sure. So one thing I always recommend is to not use alcohol-containing mouthwashes, because I think that really sets people up for mucositis. But then also, if they're having trouble with mucositis, avoiding spicy, acidic foods, and again, that like hard, crusty foods like hard, crusty bread. And then we also can use a lidocaine-based mouthwash to help symptomatically.
Yeah, that's great. And the other kind of unique toxicity I find really fascinating, given that, it's got the same payload deruxtecan as TDXD, but the toxicities with Dato-DXd are so unique. How do you grade ocular toxicity, and can you talk a little bit about, what the incidence is for the various ADCs?
Sure. So you can get dry eye with SASI and TDXD, but really it's uncommon. But with the Dato-DXD, I'd say about half of our patients, or maybe more, are having at least some symptoms of ocular toxicity. And really, they just are complaining of dry eye, and then again, the blurry vision, which really has a huge impact on quality of life because it prevents people from doing things they really enjoy. And then if it's severe, you can get corneal ulceration or perforation, which is life-changing.
Yeah, no. So how are you educating patients? What are you prophylaxing them with as you're incorporating Dato-DXd into your clinical practice?
Sure. So we have all of our patients get a baseline exam with ophthalmology or optometry. just to make sure that they're not starting with any particular problems. And then we instruct them to use artificial tears eye drops 4 times a day. And if they wear contact lenses, we unfortunately tell them they should not wear contact lenses.
That can be really challenging as someone who
Right.
struggles with dry eyes unrelated to therapy and really loves her contact lenses. So I think definitely we can think about, the impact on quality of life there. Talk to me a little bit about trastuzumab deruxtecan, which we know is now approved for HER2 low and HER2 ultra low metastatic breast cancer, both in patients who have triple negative disease as well as hormone receptor positive disease. I think based on the Destiny Breast 04 and then Destiny Breast 06 now, trials looking at ultra low disease. To walk us through a little bit of some of the side effects that are unique and distinct with trastuzumab deruxtecan.
Sure. And I think it's really important because as the indication has broadened, many, many, many of our patients, if not all, are eligible to get TDXD. So a lot of our patients will be on this. And so we see a lot of neutropenia and some anemia. There's a fair amount of nausea with the TDXD and fatigue. I think that's particular for the TDXD.
Yeah, I know very early days with TDXD, I really had many patients struggle with the nausea, so much
Yeah.
so that I was bringing them back a week later for additional fluids and IV antiemetics. But, I've recently, not so recently now, incorporated low dose olanzapine daily into my clinical
Yes.
practice, and that has just been game changing for patients and the nausea and vomiting with TDXD. So I think definitely a trick that can be used here. What about interstitial lung disease? We hear an awful lot about that. Obviously, that's a major concern with TDXD. Can you talk us through a little bit of how we grade ILD, what the incidence is with the various different antibody drug conjugates that are approved out there?
Sure. So extremely low incidence with sacituzumab and Dato-DXd. But the pneumonitis across all trials of TDXD, the incidence is about 15%. So not insignificant. And it is a toxicity that we need to recognize and intervene early. Grade 1 is when we just see it on CAT scan. We do a chest CT on all our patients after 2 cycles, just looking in particular for pneumonitis. Grade 2 is when patients become symptomatic. They have some short of breath, particularly dyspnea on exertion and a dry cough. And then again, grade 3 and grade 4, patients are, needing oxygen, hospitalized, and it's life-threatening.
Yeah, no, and I think definitely is a challenge. So when you have a patient who's got interstitial lung disease, how do you manage them? Are you holding therapy? Are you keeping it going? What are your strategies?
Sure. When we just see ground glass opacities on scan and no symptoms, we certainly are holding therapy. But if it resolves, we repeat the chest CT. If it resolves within 28 days, we actually will cautiously restart at the same dose, and we keep a very close eye. So short interval chest CTs following this. But if it's anything other than grade 1, if patients are symptomatic, we are certainly putting patients on corticosteroids right away. We consult our pulmonary colleagues to help us, and we permanently discontinue TDXD.
Yeah, there was an interesting oral abstract at ASCO this year about rechallenging patients with grade 2 ILD and sort of the safety there and whether or not the ILD will recur or not. But I think, small studies, there's obviously much more work that we need to do in this space. But, the potential to maybe rechallenge some of these grade 2s potentially could emerge in the future. It's really sad when we have to stop this therapy permanently for patients, given how effective it can be. But again, we need to balance that with the risk of fatal interstitial lung disease, and so not wanting to cause harm to patients. What about nausea? All of these ADCs can cause some nausea to varying degrees. How are you managing these patients? Are you using preventative strategies? What do you do if they have nausea?
Sure. So they're all considered highly emetogenic, but as we talked about before, we see a fair amount with T-DXd, I think more so than the others. But we pre-medicate everyone with a 3-drug regimen with a 5-HT3 receptor antagonist, a long-acting dexamethasone, fosaprepitant. We then have patients taking dexamethasone for 2 to 3 days afterwards. And then we use prochlorperazine as needed, ondansetron as needed after 3 days because of the long-acting polonocetrone that we use. And if people are having particular trouble, as you mentioned, we can add low-dose olanzapine. We have nice data to support this. We can use it as a pre-medication and then also continue it at home. I have had some patients who have been particularly sedated with olanzapine, and so we used to use 10 milligrams, but now we use 5, sometimes even 2.5, or sometimes bedtime dosing I have found is very helpful for patients because it gets their nausea under control at night, helps them sleep, and they wake up feeling much better.
Yeah. I have to say I use the 2.5 milligrams at nighttime of olanzapine, and have found that that has been game changing for patients, particularly with T-DXd. It is important to note, though, it can't be used at the same time as compazine, given the drug-drug interaction there. So I think really interesting. What other non-pharmacologic interventions are you recommending for your patients who are struggling with nausea?
Sure. So I always tell people that they really don't want to have an empty stomach. This makes nausea worse. So having small, frequent meals throughout the day is really important. Exercise has been shown to be really helpful, particularly outside in the fresh air. So I really encourage patients to do that as much as they can. Ginger infused in tea, peppermint aromatherapy, avoiding really greasy, spicy foods or foods with a very strong odor is helpful. And then a little less data, but some data to suggest that progressive muscle relaxation and massage therapy, acupuncture, auricular point therapy, which is the acupuncture done in the ear. We actually have therapists who offer this to patients in clinic while they're getting infusions, which is really lovely. And then music therapy. There's some data, particularly actually in children, not as much in adults, but that's pretty interesting as an intervention.
Yeah, well, that's great. And thank you so much, Jennifer, for really walking us through all of these ADCs and their side effects and the management of these side effects. I think, just bringing it back to our patient and, talking about how important it is to empower patients so that they understand what the side effects are, what they can do to mitigate these side effects, and also, when they should reach out to their provider if what they're using isn't working, I think is really important. So in the last few minutes, I'd just like to, talk a little bit about the management of patients. I can't emphasize enough how important it is that we practice a team-based approach for patients who have cancer and on therapies. The team includes not just the oncologists, the nurses, our advanced practice providers like Jennifer here, who's so skilled in helping to manage these side effects, but caregivers, other subspecialists who are helping to manage some other side effects like the interstitial lung disease or GI toxicities or things like that we're seeing with these patients is obviously very important. It's obviously very important to develop that team, to communicate well with the team. There needs to be open communication when we're referring patients to subspecialists or talking to other caregivers who are part of the patient care team. I think it's just really important to think about communication and collaborating to provide the best care that we can for patients. And that's obviously very important. Communication and collaboration skills are take time to hone. And so I think it's just really important when we're thinking about communication with other members of the care team, or even those who are beyond that kind of immediate care team, that we need to think about the patients first and foremost, and how we can all work together and communicate and collaborate to provide the best care for our patients. And lastly, I'd like to just leave you with some SMART goals. SMART stands for smart, measurable, attainable, relevant, and timely. And the goals here are really intended to be actions that you can implement in your clinical practice, starting right away to provide the best care that we can for our patients. I would also like to point out that Ms. Benjamin, our patient who was very kind to be part of this program, did receive an antibody drug conjugate as part of a clinical trial. She's been on this agent for over a year and a half now. Definitely has experienced some side effects that have been mitigated with dose modification, dose interruption strategies, but she is tolerating her therapy well and living her life to its fullest. Of note, she shared with us that she recently took her daughter to a Beyonce concert and had a wonderful time. So I think I just want to share with you that patients can do very well. They can live their best lives while they're on therapy for their advanced stage disease, and we should do all that we can as healthcare providers to help them achieve their goals. Today's program was the third of 3 activities discussing ADCs and their use in treating patients with HER2-negative metastatic breast cancer, and I do hope that you'll join me for the other 2 programs as well. And I'd like to thank CEC Oncology for providing today's program, as well as Jennifer for joining me today, and our patient for sharing her story and her journey with us. And a big thank you to you, our audience, for providing